Can you hear me?
Yes.
Hello?
Yes, doctor.
Okay, we are waiting for emergency CS. You can start because they may take some time. Can I stay outside for a while? Okay. Oh, automatic. Okay, I forgot. Don't worry. Okay, so you can start now.
Okay. Can you see my slide?
Yes, I can see.
Yes.
Okay, Assalamualaikum. So I'll continue the presentation. I have three procedures to present: nasogastric tube, percutaneous endoscopic gastrotomy, and chest tube. So first, my name is Nurina Imani, and I will start with the nasogastric tube. So what is a nasogastric tube? It is a small tube that goes into the stomach through the nose. So it is a long, thin, hollow tube which is passed through the nostril of the nose into the throat and into the stomach. So this tube is usually used for feeding in a child that who is unable to take food orally, or maybe they are not safely able to take food by mouth. So the indication for NG tube is a child in impaired swallowing, for example, in the case of cerebral palsy, congenital anomaly of the GI tract, and in neurological problem, impaired absorption, such as in short bowel syndrome, cystic fibrosis, and Crohn's disease, excessive metabolic demand, children with critical illness, or infant with sepsis, congenital heart disease, or bronchopulmonary disease. So the contraindication, the absolute contraindication is unstable airway, intestinal perforation, cervical spine trauma, and facial trauma, whereby you cannot put NG tube in. For relative contraindication is for patients that have coagulopathy, risk of bleeding, thrombocytopenia, and also a patient who had recent intestinal tract surgery. Okay. Next, what equipment do we need for the procedure? So first, we need NG tube of various sizes. So for neonate, the NG tube size is 6 French. Infant to 5 years old, the NG tube size is 8 French, and for children over 5 years old is 8 to 10 French NG tube. Then we need 10 ml syringe, permanent writing marker for indicator, then straw, a glass of water, and lubricant gel. Okay, firstly, before inserting the NG tube, we need to measure. So how to measure the NG tube? So you need to have the child in upright position. So for babies, you need to lay the baby face up with their chin slightly raised. Then you hold the end of the tube with holes, as in the picture, at the child's nostril and begin measuring from the holes. Then you measure the NG tube from the nostril to the base of the earlobe, about halfway between the chest and the belly button, and down halfway between the chest and the belly button. Then you mark this measurement on the tube with the permanent marker. Okay, as shown in the picture. On your left for the infant, on your right for the older children. Okay, you measure from the nostril to down to the earlobe, then to the area between the chest and the belly button. Okay. So prior to inserting the tube, so you need to have informed consent from the parent, then wash your hand, then position the child. First lubricate the tube. And then you insert the tube into the nostril, pushing it gently down until the mark on the tube at the tip of the nose. So during this process, for older child, you can ask the child to swallow, or maybe you can give the child water with straw to swallow together when you inserting the tube. So once the tube is in place, you can secure it in place. You have to check for tube placement. So how do you want to check for placement of the tube? First, you can auscultate the stomach. Here, is there any air sound? Then or maybe you can withdraw about 2 ml of stomach content. Then you test it using a litmus paper. Or maybe you can do a chest X-ray. Okay, that's for nasogastric tube. So next, for percutaneous endoscopic gastrotomy tube. So what is a percutaneous endoscopic gastrotomy? Is a flexible feeding tube that is placed through the abdominal wall and into the stomach. So what is its function? So PEG function, it allows nutrition, fluid, and or medication to be put directly into the stomach, bypass the mouth and the esophagus. I prepared a video for better explanation.
Your doctor may perform a percutaneous endoscopic gastrostomy, or PEG, to insert a feeding tube into your stomach if you are unable to take food by mouth for an extended period of time. Digestion of food begins in the mouth. When you swallow, food is pushed down into your esophagus, a muscular tube that carries food to your stomach where it is digested. From the stomach, food travels to your small intestine, where digestion continues and nutrients are absorbed into the bloodstream. Your doctor may require a PEG feeding tube if you cannot eat, digest, or absorb food due to esophageal cancer, oral surgery, or stroke, major surgery, trauma, burns, or anorexia, inflammation of the pancreas, or radiation therapy, or inflammatory bowel disease affecting the small intestine. Before the procedure, you'll receive a sedative through an IV to help you relax. A local anesthetic will be administered at the site on your abdomen where the PEG tube is to be placed. The most commonly used PEG placement procedure is the pull method. During this procedure, your doctor will insert a lighted endoscope through your mouth and thread it down your esophagus and into your stomach. A camera attached to the endoscope will produce images of the inside of your stomach, which will be displayed on a video monitor. Next, your doctor will insert a needle through your skin into your stomach at the location where the PEG tube is to be placed. While doing this, he or she will use the endoscope to locate the end of the needle inside your stomach and encircle it with a wire snare. Your doctor will then pass a thin wire through this needle into your stomach, attach the endoscope to the wire, and pull both the endoscope and wire out through your mouth. At this point, there will be a thin wire entering the front of your abdomen into your stomach and continuing upward and out of your mouth. Your doctor will attach the PEG feeding tube to the wire outside of your mouth. By gently tugging on the other end of the wire, he or she will pull the tube back through your mouth and esophagus and into your stomach. Your doctor will continue to pull until the tip of the tube comes out of the incisions in your stomach and abdomen. A soft round bumper attached to the portion of the tube that remains inside the stomach secures it in place. The outer portion of the tube will be secured with a bumper as well. A sterile gauze will be placed around the incision site. In the alternative push method, the doctor will begin in the same fashion by using an endoscope to guide a wire through your abdominal
we need to
wall
hold for a
and
while.
into your stomach.
Okay.
But instead of pulling,
Yes, doctor. Doctor, can I continue?
Okay, let's go.
Okay, Doctor.
Inshallah, soon you will come to the OR to attend the babies and know how to resuscitate him. What is the name of this?
Name of this?
We can done. Okay. Go ahead for your presentation of chest tube.
Okay, the remaining part of my video, there's another
Yes, you can see the video. No issue with the video.
yes.
Okay. Here is the stethoscope, Doctor. Okay, go ahead. No need for the video now.
Okay. So there's another method which is called push method. The tube is inserted from the outside rather than compared from the pull method in the inside. So for PEG tube complication, it can be the complication can be dislodge, tube dislodge, aspiration, whereby the aspiration then bleeding, and also it can cause infection near the insertion site. Okay. Next, for the chest tube. So a chest tube is a tube used to evacuate of any abnormal amount of fluid or air in the pleural space. So the indication for chest tube is tension pneumothorax, hemothorax, and empyema. So the contraindication for chest tube is bleeding, diastasis due to coagulopathy, skin infection over the chest tube insertion site. Okay. So the technique for the chest tube. So we have to safely locate the safe triangle. It's just the picture on your right. We have to locate the pectoralis major muscle, then the latissimus dorsi muscle, in between the fifth intercostal space, and at the mid-axillary line. So these are the region that are safe for its chest tube insertion. So firstly, for the technique, we have to obtain and inform consent from the patient or the parent. Then you have to position the patient in a supine or 45-degree with the hand raised upwards. Then, as I mentioned earlier, identify the safe triangle region. Then local anesthetic is given at the incision site. Okay, then proximal end of thoracostomy tube clamped together with the Kelly, and then it is inserted into the pleural space. Okay. Then it is secured and taped to its place. Okay. The complication for chest tube, it can cause neurovascular injury, can cause pain, improper placement of the chest tube, and so it can cause infection, injury to the internal organs, and also it can cause bleeding. Okay, that's all.
Okay, so what is the definition of tension pneumothorax? Baby is okay? Everything is okay? Everything is okay? Say mashallah. And they prepare the ultrasound machine to see the temperature. Okay? Prepare the ultrasound machine. Yes. So what is the definition of tension pneumothorax?
Tension pneumothorax is when there's lung collapse due to trauma.
Sorry? Pneumothorax, we know. We know what is a pneumothorax. Pneumo means air. Thorax means chest. I mean here inside the pleural cavity. Okay? But the tension. I am advising you any time you just new expression in medicine, new definition, you must try to just ask Mr. Google for 1 second or 2 seconds to tell you what is the meaning. Okay, so that your software will be built with a lot of knowledge, which is very important in your practice. Okay, thank you. So the tension means that there is considerable amount of air inside the pleural cavity, which is pushing the mediastinum to the other side. What can it cause? Suppose someone picked the mediastinum and they kicked the major arteries. What will happen? It is like the same killing someone. Yes, that's why this is a medical emergency. So to know what to do are very important. Okay, just oil. So we know now that the tension pneumothorax is a medical emergency. You must take care while you are inserting the ICT tube. Okay, a very important point is you are inserting it in the intercostal space. Yes, at which intercostal space?
Fifth intercostal space. Fifth in
Again?
Intercostal space.
Where? Because the mid-clavicular line, if it is 4, if you go to the anterior axillary, it may be 5. If you go to the mid-axillary, so you must be able to define which one. Okay? And where to put it, which area, the intercostal space, even if it is small, you must know where to put it. So what's your suggestion to put the intercostal chest tube, the ICT tube? Here is 2 ribs in front of will insert. Remember that the ribs are very sympathized. The ribs are very sympathized like a mother. So he is covering, the rib is covering the nerve, the artery, the veins. Okay? So if you are trying to enter, you must go from the upper, the tip of it, not from the rib.
Below.
So if this space, you must go for the upper tip of the rib. which is number 4 or like that, not to the lower end of the tip, which is number 3. Is it clear? Otherwise, the patient can get bleeding and complicated. Is it clear? Hello?
Mm.
Okay.
Yes, doctor.
Okay.
Now we got an important lesson about the mini tubes. Okay. And really, any doctor needs to be experienced in few numbers of tubes, which will make him very
Dilate. Doctor.
okay. So few tubes you already taught how to do it. It will make your practice are very simple, starting from the Pt2 tube, from the continuous drainage of the bladder, for a lot of things. If you know a lot about it, you will be very clever. ICT, after that, you know how to insert a central line.
I think there's no need to cover because a patient has GM on high insulin. And finally, a mother has a urine, UTI during November, but UBCNS no growth, they cover with cetoxin. HBS also no growth. So
yeah, for antibiotic, I'm
resource.
not speaking. I need to close monitoring of the.
yeah, but no need blood CNS
RBS.
and gentle.
If he behave like infection, would do. Otherwise, no need.
So
No need, but dextrose monitoring and the monitoring his pre and post ductal are very important. And to see, usually, if the baby starts to lose some edema, it will appear he has anomaly or not. I'm coming just 1 hour maybe. Okay, who will be the second presenter?
Sorry, I have a question.
Sorry.
I have a question. Can I ask?
Yes, of course.
For PEG tube,
Yes.
gastrotomy tube. So for how long did the patient need to be on gastrotomy tube?
It depends on the patient. There is some patient who will be needed for their life. If the patient has bulbar or pseudobulbar palsy, that's to say he is unable to swallow, he is unable to suck like that. So he may need it for life, but the surgeon will answer for you if they need to change it, if something happen or if not happens, for how long. It depends on the instructions from the surgeon.
Oh, all right, okay.
Okay, it is the same like many processes in medicine. They will inform you this one can stay for how long, like that. Okay.
Okay,
But
doctor.
usually we are not inserting it unless the patient needs a long-term feeding by this tube. If it is a short time, we will use the simple one. Okay. So what's your name again? Your name?
Nurina.
Norina. Norina? Okay.
Yes.
Okay. Who will be the second one
Me.
to present?
I'm Alia.
Okay, Norina Alia. Okay. I will just shift to the other because they may contact me. You can go.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I will proceed to the next procedure, which is the central access of umbilical artery and vein catheterization. You can see my slide, right?
Yes.
Okay. So this is my outline. Okay, next. Okay, what is the umbilical artery and vein catheterization? It is an invasive procedure and should be done under supervision in an LCU setting. So what is the indications? So we go to the artery first. It is for repeated blood sampling in ill newborn, especially those on ventilator. For example, to want to have a repeated blood sampling like arterial blood gases sampling. Second, occasionally it is used for continuous blood pressure monitoring. For example, monitoring arterial blood pressure and infusion of maintenance fluids when other routes are not available. The third one is angiography and fourth one is resuscitation. Okay. For vein, the indication are mainly for emergency resuscitation. Second is as a venous access in preterm babies, especially extremely lower birth weight, which is less than 1,000 grams, and also sick babies in shock with peripheral vasoconstriction. Other than emergency resuscitation, umbilical vein catheterization is also for doing exchange transfusion for severe neonatal jaundice. So what is the contraindication? So for artery, there will be local, if it is contraindicated if there is local vascular compromise in the lower extremities. Second, if there is peritonitis. Third, necrotizing enterocolitis, and fourth is omphalitis, and also omphalocele or other abdominal wall defects such as gastroschisis. For vein, also the same, but different is that vein is not involved with the local vascular extremities. Okay. So next I will talk about the placement for arterial catheter, umbilical arterial catheter. They have two position, which is high lying position and low lying position. For high lying position, it is located at T6 to T9 above the diaphragm, which is above the celiac and mesenteric roots and renal arteries. For low-lying position, at L3 to L4 above the aortic bifurcation. Okay. So for venous catheter position, it is located at T8 to T9, just below the diaphragm on X-ray, and it will pass through the ductus venosus and at the junction of the inferior vena cava with the right atrium. If the catheter does not pass through the ductus venosus, usually it will lie within the portal vein and will cannot further advance. If so, we should withdraw it until it is possible to sample blood easily via the distal lumen. So, for all the umbilical catheters, after finish the procedure, must be X-rayed to confirm the appropriate placement. Okay, so this is the example of the X-ray for UAC and UVC. Okay. Besides knowing the right position, before we start the procedure, we need to do a big calculation of insertion distance. There are two most commonly used methods, which are by Dan and also Shukla and Ferrara. What I provide here is a calculation from Shukla and Ferrara, which is for UVC 1.5 times birth weight plus 5 centimeter, and UAC 3 times birth weight plus 9 centimeter. So remember, for both these calculation, need to add the stem length. Okay, so we go prior to the procedure, especially for the umbilical artery catheter. We need to examine the infant lower extremities and buttocks for any signs of vascular insufficiency. Second, we need to palpate femoral pulses for their presence and equality. And third, we need to evaluate the infant's legs, feet, and toes for any asymmetry in color, visible bruising, or vascular insufficiency. And lastly, we need to document findings for later comparison. And do not set if there is any sign of vascular insufficiency. As I mentioned just now, it is contraindicated. Okay, so these are the equipments. As the procedure is sterile, so we need to have the sterile gown, gloves, and face mask. And then we have a UAC and UVC set, which consists of forceps, scissors, Kelly clamps, scalpel, iris forceps, umbilical tie, cord clamp, and also sterile grab and sterile gloves. And another next is we have three-way tap, 5cc syringe, and heparinized saline for infusion later. And not to forget the catheter itself. So for umbilical artery catheter, for size 2.5 French, it is for babies who are less than 800 grams, and most for less than 1000 grams. For size 3.5 French is for preterm infants more than 1500 grams. For size 5 French is for interim infants. For umbilical venous catheter, there are two sizes, which is for 3.5 French is for birth weight less than 1000 to 1500 grams, while 3 French for birth weight more than 1500 grams. Okay, so we start the procedure with preparation for both umbilical artery catheter and for venous catheter is quite the same. So I go first for the preparation, which is we need to position the baby in supine position on a radiant warmer. The infant's arm and leg should be secured to avoid any movement. And then, as I mentioned just now, we need to make measurements of depth catheter insertion by the calculation before. And then we need to fully scrub. Okay. After we fully scrub, we need to prepare the set. So check all the set, the equipments, is it available, and then is it works well, flush every lumen of the catheter. Okay, and then we ask an assistant to grasp the cord with cord clamp. Like in this picture, we grasp the cord with cord clamp and ask the assistant to apply traction vertically. And then we will apply a septic solution to the cord surrounding the skin, to the cord and surrounding the skin. And then we apply surgical drag. Okay, after that, we will wrap cord tie around the base of the umbilicus, and we will tie it with a single knot. The knot should be tight enough to prevent bleeding from the cord, but loose enough to allow the catheter to pass through the vessel. Okay, and then we cut the cord horizontally and approximately 1.5 centimeter from the skin, and then we should take care not to cut the skin that is at the base of the cord. So we will leaving behind about 1 centimeter stump. Okay, then ask the assistant to remove the cut cord and clamp. Okay, then we identify the vessels within the cord. There will be 2 arteries and 1 vein. The artery is smaller in diameter, wide and constricted. If there is any bleeding, we need to control by adjusting the tension on the umbilical tie that we tie just now, and by blotting, not rubbing the freshly cut surface. Okay. Okay, so next, we go to the artery first, umbilical artery catheter. So the assistant will help you to grab the side of the cord near the artery to be cannulated. Then you will clamp the opposite side, so you will get a traction like this. So that you can have a obvious vessel for you, easier way for you to put the catheter inside. Okay, then before we proceed with the catheter, we need to dilate the artery first. So we put a pinch tip of curved iris forceps into the lumen, about 0.5 centimeter. Then we remove to allow it to dilate. And then we place again for 1 centimeter depth. And then we allow the forceps to open slowly. Just now it's closed tip. Right now it's open slowly, and then maintain at that position for about 20 seconds for the vessel to dilate completely. And then
Usually we have umbilical artery dilator.
okay.
It is more safe.
Okay. Thank you,
Because
doctor.
if you injure the artery, it will start to bleed. Okay.
Okay. All right. Thank you, doctor. So like doctor mentioned, we have the artery dilator, so we use that to dilate the vessels. Okay, and then we insert the catheter. Okay, we slide the catheter with firm, steady motion, past 1.5 to 2 centimeter. Okay, into the artery, and then once depth 5 centimeter, try to draw back with switch to look for any blood flow. Okay, if the catheter already passed the predetermined depth, we may encounter resistance. So we can secure the catheter there. And important thing is that the vessel will slowly relax and it will not pop as you apply constant pressure. If the vessel pop, which means there is perforation to the artery. So we need to remove immediately the catheter and do not apply again inside the same artery. Instead, we go to the other artery. Okay, as we know, there are two umbilical artery. Okay, so then we need to confirm the placement with X-ray, and we need to secure the catheter with a purse string suture. Avoid puncturing the catheter, vessels, or the skin. Okay. Before secure the catheter, we need to observe for signs of arterial ischemia to the lower limbs and buttocks. We need to check the color, cold skin, capillary refill delay, poor dorsalis pedis, and posterior tibial pulses during and after the procedure due to arterial vasospasm. If there is no complication, then we can secure it.
Yeah, remember that as your colleague presented before with Ellen, it started to blanch and then after that started to be cyanosed and like that. Okay.
Yes. Thank you, doctor. Okay, so next, so post-procedure care, we can monitor the lower limbs and buttock for ischemic changes 2 to 4 hourly. Second, we infuse the heparinized saline continuously through the catheter to reduce risk of catheter occlusion and thrombotic events. Third, we need to note the catheter length markings every day and compare with the initial length to check for any catheter migration. And fourth, we need to remove UAC as soon as no longer required to reduce the incidence of thrombus formation and long line sepsis. Okay. For umbilical venous catheter, the steps is similar to the arterial catheterization, it's a bit similar, but the difference is we put the catheter at the umbilical vein. So sometimes we continue after we settle with the umbilical artery catheterization, then we hold we need to identify the umbilical vein, which is thin wall, patellus, and usually seated at the 12 o'clock position. And the blood of umbilical vein is dark red in color. So we need, if you stand to the right of the baby, if you are right-handed, then tilt the umbilical stump inferiorly at an angle 45 degrees from the abdomen. And then you insert the catheter superiorly and posteriorly towards the direction of the right atrium. Okay. Then put it as far as lead to get the blood return. And then you flush the line to aspirate back to confirm the blood return. and to clear the line bubble. So then after you already confirm the press, after that you need to confirm the placement and also suture to secure the position. Okay, and we need to consider removing of UVC after 5 to 7 days to reduce incidence of line sepsis or thrombus forming around the catheter. So there are few complications for UAC and UVC. Some of them is overlap. Okay, for UAC, there will be bleeding from accidental disconnection and open connection. Second, embolization of the blood clot or air in the infusion system. Third, there might be vasospasm or thrombosis of aorta, iliac, femoral, or obturator artery, which can lead to limb or buttock ischemia. And then fourth is thrombosis of renal artery or mesenteric artery. For renal artery, the presentation like hypertension, hematuria, and renal failure. For mesenteric artery, it can be present with gut ischemia, necrotizing enterocolitis. Okay, next, there will be have vascular perforation of umbilical arteries, hematoma, and retrograde arterial bleeding. And lastly, nosocomial infection. For UVC, first is infections. Second, vessel perforation. Third, thromboembolic, like in the lungs, liver, and even other systemic circulation. And then pericardial tamponade and arrhythmias can be caused due to wrong position of the UVC. And then the hydrothorax, portal vein thrombosis and portal hypertension, and also hepatic abscess. Okay, I think that's all from me, and this is my reference. Thank you. Is there any question?
Okay, good. So we know now that we are using the vessel through the umbilical as a central line in the neonate. We have the umbilical, we have 2 artery and 1 vein. Okay, the artery is rounded and strong, and the wall is thick but small. The vein is patulous. So just you need to try to pick the artery first if you are able, and then go for the vein, because the artery will go to spasm very soon after cutting. If you are 2 and 1 can pick here and 1 can pick on the other side, just to introduce the catheter, it will help also, okay? So it is better to start by the UEC. The important thing here also, now there is many researchers working now for a machine known as artificial placenta. To just said, subhanallah, they are doing one big room now. They are trying to make the function of the placenta and bring it out as a 2 vessel. Just after delivery of the preterm, they cut from the mother and go for the umbilical arteries and vein, and they connect and leave the baby to continue the timing. I think they now on the 7th year, they said we need up to 10 years of trials and like that to come to the conclusion. That's why to say, subhanallah, something we are just go and through this placenta, it finished its function. Now to do one like it needs how much time, how much effort, how much, but this is our cases. So always search, always think in advance. Even our scholar before, even the scholar for Islam, they are not just making a routine life. Usually if they have time, they will suggest and think and try to put a proposal and the treatment of this proposal. Otherwise, we are not able to do a lot of that. They are thinking if this thing happen, what is opinion of Islam, what this thing happen, what we will do, and then if you open this book, you will find a lot of working minds, and the Muslim need to have this point. It is very important. Okay, good. The last presenter, or did you present all? Do we still have one more presentation?
Yes, doctor. About central line.
Yes, doctor.
Okay, go ahead.
Okay. Okay, I will present about the central line or central venous catheter. Next. Okay, so for the central venous catheter, we have three sides actually: the femoral vein, the internal jugular vein, subclavian vein, and we also can do PICC, which is peripherally inserted central catheter. Means that we insert it peripherally, but the catheter is not in the peripheral vein; it is in the central vein. So that means peripherally inserted central catheter. And in this presentation, I will focus more on femoral vein because it is most common used in the pediatric patient. However, all these veins have similar insertion technique. However, what differentiates is the lemma of the vein, and all other steps are similar. Okay, next. Okay, so for the indication of the central venous catheter is when there is inadequate peripheral venous access, or where is emergency resusc, where we need to resusc the patient immediately. So we opt for the central venous catheter so that we can restore the volume faster. And then for hemodynamic monitoring, for example, the central venous access to permit the measurement of central venous pressure, venous oxyhemoglobin saturation, and also cardiac parameter. And also for pulmonary artery catheterization, this one is for monitor the drug monitoring for the heart failure, and then frequent blood draw so that we don't put the patient with multiple times, especially the pediatric patients. So it's better for us to insert the central venous catheter. And then for the longer term intravenous infusion, for example, the hyperelimation, concentrated solution, or vasoactive substances that can irritate the peripheral vein. So we use the central venous catheter. For example, the vasoactive substance, potassium chloride, chemotherapy agents, and also hyperosmolar saline. Okay, next is the contraindication of central venous catheter is when there is absent or trained doctor for this procedure. For a patient yang ada distorted anatomy or landmarks, for example, we cannot determine where is the femoral vein because it is distorted. So we can, it is contraindication, but remember, like I mentioned before, we have three sites for insertion of the central venous catheter. So if the femoral vein is distorted, so we can go to the internal jugular vein or subclavian vein. And then when there is bleeding protein disorder, for example, thrombocytopenia, coagulopathy, and patient on anticoagulant or thrombolytic therapy. And then when there is a skin lesion, for example, cellulitis, burns, abrasion, or dermatitis, because when we do the we puncture the skin at this side, it can lead to introduction of the microorganism to the bloodstream. So it can lead to central line associated bloodstream infection. And then contaminated or potentially contaminated sites such as local skin infection or proximity to a wound, burn, or tracheostomy should be avoided. And also when there is a vascular injury proximal to the insertion site, for example, thrombosis of the targeted vein. Next. So like I mentioned before, I will focus about femoral venous catheterization because this is most commonly accessed central line site in the pediatric resuscitation. And because it's relatively easy to access and is system for the major site of the activity during resuscitation. Next. So for the equipment, usually we use the sterile set, self-dangle cannulation set, for example, the sherry, needle, guide wire, and then we need tissue dilator. And also we have to have 5 ml sharing. This one is to flush the pot after we insert the catheter. And then we need anesthesia to reduce the pain in this patient, which is we need 1% lidocaine. And then skin preparation solution where we need 2% chlorhexidine based preparation for the patient older than 2 months, or we can take 10% povidone iodine. or sterile dressing. For example, the face mask, hair cap, sterile gown, and also glove. Okay, this is equipment that we needed, like triple lumen catheter, the shearing weight needle, the guide wire, the shearing, and also the scalpel to make incision of the skin. Okay, next. So the positioning for the femoral central placement, must place the patient in the supine position. We can raise the hip slightly to flatten the inguinal area by placing the towel under the hips, or we position the patient with the hips and knees slightly flat or in the frog position. Okay, next. Okay, for us to make femoral vein catheterization, we need to know the landmark so that we don't injure other structure. For example, the femoral artery that are in close proximity to the femoral vein. So first we have to locate the femoral artery pass in the mid-inguinal ligament, and then we move 1 to 2 centimeter inferior to this position. But okay, so this is femoral artery, but we want to puncture the femoral vein. So femoral vein, we know that femoral vein are located medial to the femoral artery. So in the infant, we go 5 to 6 millimeter medially, and in adolescent 10 to 15 millimeter medially. So we put this place for the femoral vein. However, it's recommended to use ultrasound guidance since currently ultrasound are widely available, so it's better for us to use ultrasound. Okay, next. So ultrasound can visualize dimension and position of femoral vein in relation to femoral artery. So how we want to know, is it femoral vein or femoral artery based on ultrasound? This is when we compress the skin, our skin with the ultrasound, the vein will appear collapsed while artery are not. So the one that collapsible, we put this part with the tip of the needle. Okay, next. Okay, and you can see that the picture B showing the tip of the needle in the compressible vein. It's not in the artery. So this is how we monitor it. We did not inject the artery. Okay, next. So the insertion technique, first we have to clean the inguinal region thoroughly using the iodine and 70% alcohol. Okay. And then we have to infiltrate local lidocaine at the proper site of the skin insertion. And then while palpating the femoral artery that we just determined just now, then we puncture the skin immediately by advancing needle at 30 to 40 angle to the skin toward the umbilicus. And we must make sure we don't we maintain palpation of femoral artery to avoid from puncturing into the artery. Okay, next. After we advance the needle, we use the Sandiger technique. And when we advance the needle, we see the blood backflow. So what we do right now is we disconnect the shearing from the needle. We leave the needle into the vein. And then after we leave the needle into the vein, we insert the guide wire the needle, and we advance the guide wire into the vein. And then after that, we withdraw the needle after the guide wire is inserted into the vein. However, we must make sure that the guide wire doesn't detach together with the needle. And then we make small skin incision on the skin and introduce the dilator because we want to make the hole be enough to catheter to insert through. And then we insert the catheter until it located above the confluence of the iliac veins. And then after that, we remove the guide wire just now. And then secure the catheter by suturing. And we have to flush all 3 ports with normal saline. Okay, next. Okay, and then after we do that procedure, we have to confirm the placement of the tip of the catheter via the X-ray. And then the complication can be divided into during catheter placement and with catheter placement. So during catheter placement, the complication are the arterial puncture, local hematoma, bowel or bladder perforation, air embolus, catheter embolus, arteriovenous fistula, and pseudoaneurysm. And with catheter placement, it have high risk for the infection because we introduce the foreign foreign object into our bloodstream, and then swelling of the lower extremity resulting from the impaired venous rhythm, and then deep venous thrombosis or inferior vena cava thrombosis, catheter knotting and catheter malposition. Okay, next. Okay, this one is the catheter line associated bloodstream infection. It is defined as laboratory confirmed bloodstream infection and not related to infection of another site and developed within 48 hours of central line placement. So we can prevent this from happen by performing the hand hygiene, apply appropriate skin antiseptic, and ensure that the skin agent has completely dried before inserting the central line, and use all 5 maximum sterile barrier precautions. But we can use sterile gloves, sterile gown, cap, mask, and last sterile drip. And once the central line is in place, we have to follow the recommended central line maintenance practice. We have to educate the patient to wash their hand with soap and water or alcohol-based hand rub before and after touching the line. And when we doesn't need the central line, so we have to remove it as soon as possible. Okay, next. Okay, next one is the preferably inserted central catheter. It's a 5 plastic tube that length about 10 to 50 centimeter long. It is inserted into one of the veins, usually in the upper or lower limb, until it reaches a point where the veins are much larger. Usually that just outside the heart. You can see the picture that the tip of the catheter is in the superior vena cava, outside the heart, not in the heart. And this PICC line can stay in 4 weeks, 2 months. And these line are flexible enough because we want to advance it for a long round, so it must be flexible so that it doesn't perforate the vein. So this indication is just the same as the central venous catheter, but it usually indicate for those that have a long-term IV medication administration because it can be there for about months. So it's useful if we want to use it for administration of long-term medication. For example, antibiotic in the infective endocarditis, where it needs about 4 to 6 weeks of the parenteral antibiotic to be administered. And then for the continual administration of vesicant or dry diuretic peripheral vein, frequent blood draw, and administration of parenteral nutrition to these babies where full enteral feeding is delayed. For example, in those very low birth weight. Next. So contraindication also just the same as central venous catheter, burns, trauma, skin infection, radiation, history of current of venous thrombosis at insertion site, active bacteremia, chronic renal failure or end-stage renal disease, because we want to preserve the vein for any potential for dialysis catheter placement later. And then abnormal clotting factor, patient with persistent cough or vomiting, because this can increase the intrathoracic pressure, which can lead to the catheter malposition, catheter erosion, or cardiac tamponade. Okay, next, there's advantages and disadvantages of the PICC, which one is fewer needle pokes throughout your treatment. Larger volume of fluid can be given more quickly, and some medication that are related to small vein can be administered through the PICC. And the disadvantages is it must be handled with care because it has high risk to get infection and complication. It can change the body image, and insertion carry a medical risk because it associated with surgical procedure and require maintenance and supply at home. Okay, next. The site for the PICC is usually at the antecubital fossa, long saphenous vein at medial malleolus, and also we can use superficial temporal vein. Type and PICC component. So PICC have many sizes, depend on vessel diameter, which correlate with the width, age, and site selection. For example, preter we use the 1 French, term 2 French, and children 2 French to 4 French. So this is example of the PICC line. Next. So equipment required for PICC, we need 2 drapes, 4 gauze ball, 2 plastic forceps, one pepper tape measure, one bionector, tegaderm, tourniquet, scissor, forceps, and then syringe, stiragown, stiragraph, face mask, and catheter head is just the same as the central venous catheter placement. Okay, next. So technique is first we have to clean and numb the skin where the PICC line goes in. And then we put the PICC line into a vein, which is at the antecubital fossa. Usually we use the antecubital fossa using the ultrasound guided. And then we advance the PICC line up to the large vein near the heart. And we need to check the placement of the PICC line with an X-ray. And then after we done it, we place a dressing over the PICC line. Okay, next, we need to confirm the position because we doesn't want the tip of the catheter to insert inside the heart because it can high risk to get arrhythmia. And then there is upper limb and lower limb placement. So the upper limb placement is at the superior vena cava above T4, and the lower limb placement in the inferior vena cava lower to T9 and lie to the right side of spinal column. And we must make sure there is no misplacement or malposition of the catheter. Okay, this one is well-sighted catheter is in the supravena cava position, and this the red one is the left arterial insertion in which it inserted into the heart. So we have to withdraw it as soon as possible because it get high risk to get arrhythmia. Okay, next. So this PICC because it stay for a long run, so we have to maintain it. So maintenance need the insertion site with the guidance dressing should be left undisturbed, and need frequent flushing of the line with saline and heparin containing solution, and sterile dressing replaced at regular intervals, remove as early as possible if not indicated. Don't do any strenuous activity or heavy lifting for the first 48 hours after the line is placed. I need to cover the line with plastic when showering so the dressing doesn't get wet. And then change the dressing I can every 7 days or sooner if the dressing starts to lift up. Okay, next. And the complication also are just the same as a coronary catheter. It get high risk of infection, catheter malposition, catheter occlusion, cardiac arrhythmia if the tip of the catheter are inserted through the heart, contrast reaction if we use the fluoroscopic guidance to check for the correct insertion of the tip of the catheter, and then puncture of the adjacent structure such as the other vein or arteries. Okay, I think that's all.
Okay, thank you. This is a good knowledge in advance. It may be you may need it soon. No one knows when, inshallah, you will start your houseman. Hoping you are strong enough to pass the final pro. So don't work with us at the level of your batch with any department. Think that there will be judgment by another level. Okay? Study hard. I just send it to your colleague, Naila.
Yeah.
I sent another.
Yeah, I received the PDF that you sent me.
Yes, I need every one of you prepare the hand washing.
Hand washing?
Hand washing, okay, very important, and the BBI level 1 and 2. Everyone must do it himself. Okay.
Hand washing, PPI level 1 and level 2.
It's for all. Every one of you need to do it alone. Okay. Then the other which I sent to you, you can give everyone just one more, and they make it in one file and send it to me.
Right, doctor.
Okay.
Do you have any preference when should we when is the due?
Allah make it simple for you. Why you are asking me? Just a good few days and finish.
And then I would like to ask.
Everyone need to add one extra, okay? Because there is some also procedure you must know some about it, okay? And you have already the just guidance for that.
And doctor, I would like to ask regarding the PE physical examination class.
Do you have any teaching session with me or not?
Pardon?
Do you have any teaching session, any case presentation, any group, either live or online?
Let me check first.
If we have, we can just, or do you need to give it to the whole batch? Do you mean the whole batch or for you alone?
No, the whole posting, the whole batch. The other day you assigned us to do to present about physical examination.
Yes. I know because I became upset from some student in the last few months with the COVID. They lost their ability to be comprehensive and know the way. Okay. Check if I have any presentation or teaching with any group of you, we can just assign extra time at that time.
Doctor.
We have online case discussion next week.
What time?
On Wednesday, 10 in the morning.
Who will be the group? Are you?
I think they don't decide yet.
Very good. So the one who will present with me, I need the two cases, they will present the two systems. Okay, and then you maybe one for introduction, one for observation, one for peripheral. Okay, and let us inshallah with the next case presentation, I will finish the remaining systemic examination. So it is good just to put it in the case presentation. But prepare yourself, it may take a bit longer time, hoping inshallah Allah bless our time. Okay?
All right, doctor.
Doctor, I have a question regarding the procedure before. For adults, the femoral line is not preferred because of hygiene. Is it different than the children?
Also, it is considerable for everyone, but we are trying just to aside it as we can. So after insertion, we have the vein artery nerve. Just when entering the vein, we are trying to make it outside, make it one stitch just lateral, so it isn't away from the pathway. And we try to put also like sterile gauze, just to try to, and whenever the situation came that the patient can get rid of it, we are going to do. But we are doing our best just to sterile and put a complete cover and put extra gauze just to protect from any soiling, okay? But still, theoretically, still. Especially if we are doing femoral artery, in case we need to do operation for the patient, like intracardiac catheter correction like that. So we need to insert for him also umbilical artery. Because usually the babies has a short neck like that, it will be easy, the femoral one.
Okay, thank you, doctor.
Remember that there is no procedure without harm. But if you know, you will avoid. If you didn't know or concentrate, you will go to it easy. It is the same if you are driving a car, driving a motorcycle, even walking on the street. You must know that there is some danger, how to avoid. This is our work in medicine, okay? Just to make the harm to the lower and the benefit to the top. Even this is Islamic principle. دفع الضر الإسلام دفع الضر أو المفسدة is first, then even to give benefit. So if you are going to give some benefit, but you find that the harm is more, you must think again. Can I take another decision or not? Okay. Thank you for your patience today and hoping to see you, inshallah, in the next.
One more thing, doctor. One more thing. Since we have limited time before we went back the other day, can they present case write-up cases? Because I think they have limited case that they have clocked before we went home.
So you are going to endorse for me case write-up?
Yeah.
With the previous batch did it. Inshallah, you will find time to come to the hospital and take, because year 5 still able to come to in ICU to get some cases for the ward. Okay, hoping. Don't worry about that, but it may be you are also squeezed for time.
Okay, thank you, doctor.
You are welcome. Okay, Assalamu alaikum. جمعة مباركة وزود برينج الجمعة. Okay.
Thank you, doctor.
Salam, thank you, doctor.
Waalaikumsalam. Thank you, doctor.